are increasing. Diagnosis is happening younger and younger, yet we're thriving and living longer. But the clinician knowledge on managing the collateral damages, including premature menopause and survivorship needs, has not kept up with the demand. Full stop. Everybody on this call, on this Zoom, knows this. This is what I hear every day from my patients on social media when I speak to the young women at the YSC summits and et cetera. So today I'm going to give you a lot of knowledge and information. I also want to get you guys a little fired up that this we need to be advocates and we need to be activists when it comes to this topic. Many of you a few years might have heard all the buzz that's just really been started on menopause in, in the general population, like regular old menopause, right? But our menopause, due to breast cancer treatment, is not normal. It's not physiologic, and it's happening, at an earlier age. But I think this is a really poignant magazine piece, New York Times Magazine, that really kind of set kind of the country on fire, got us all talking about it. And it was titled, "We Have Been Misled About Menopause." And it really, really was an important piece. And I think this quote from the article says, it suggests that we have a high cultural tolerance for women's suffering. It's not regarded as important. And this is in reference to how menopause in general is a natural life transition for every woman, but it's really been ignored and dismissed. And there's been so much misinformation about hormone therapy, that can treat symptoms in the average population. So when you bring in a breast cancer survivor, well, I think this quote that we have a high cultural tolerance for women's suffering, I think as a breast cancer survivor, many of us feel like we have to just be grateful to be alive, be grateful to have the treatments, which we are. But the collateral damages on sexual health and menopause health has really been dismissed and not well addressed. We're not represented in studies on menopause. Our symptoms are dismissed as, oh, a little hot flash and some dryness. It's much more than that. And there is no major cancer center in the United States that has a true dedicated menopause sexual health program that is really taking care of all of the aspects that happen with menopause after cancer. And then, as a follow up in the New York Times just a few weeks ago, was this article that maybe some of you saw. And it was titled, "Millions of Women Are Left Out of Menopause's Moment." Women who can't take hormone therapy because of breast cancer or other diseases say they are deeply frustrated. And it's a really important piece to read. And I actually wrote a little bit more about it, so you can go check that out. But it basically portrays what I see every day, that the women who have the most to lose and have the most to gain when we help them are the least likely to get that help for their menopause. So this is my formal invitation to you all to be part of the menopause. This is kind of a tongue-in-cheek thing that we've been saying on social media, and it's really, I reference it as really anybody, any doctor, clinician, healthcare provider, and patient or woman who is kind of fired up and want to learn and kind of move the conversation forward about valuing sexual health and menopause health care. And so breast cancer survivors, you guys get to be part of this menopause too. Even if you're estrogen receptor positive or whether you're triple negative or not, it doesn't matter. We all are dealing with menopause and we need to have adequate tools, right? And your menopause after a young breast cancer is unique. It's not normal, okay? It's not physiologic. And tonight we're going to talk about what premature menopause means for your health span. So lifespan, how long you live, but health span is how healthy you are while you live. And health span is important. We're going to talk about the genitourinary syndrome of menopause, so GSM, and how to be proactive and treat it, and how you can have a healthy and happy sex life. Yes, we're going to touch on that too. And everything that I'm going to talk about, it's always going to come back to pillars of lifestyle medicine: exercise, nutrition, sleep, stress reduction, and community, and how we can use the full toolbox that we have for menopause and cancer. We're going to learn about the difference between local and systemic hormone therapy and how those things differ and how we can talk about them, and that you need to be the CEO of your menopause health to live well, because right now no one else is taking charge of it. And so the goals of menopause care for breast cancer survivors in particular is to reduce the suffering related to menopause symptoms. This is key. help support adherence with your adjuvant endocrine therapy or other therapies, and reduce the risk of the long-term consequences of estrogen deprivation, because it's not just hot flashes. There are serious long-term consequences from this premature and prolonged estrogen loss. We're going to understand how do we balance the risks of breast cancer recurrence versus perhaps the benefits of systemic hormone therapy in select patients, and how else we can support health behaviors. So the very first part we're going to get into, and I kind of give a shock warning on this, is I've got to give you guys the hard truths of premature menopause and treatment-induced estrogen deprivation. And I often say we can't tie a pretty pink ribbon about it, around it. This is not your mother's menopause at 52. And the reason why I want to bring this up is because I just don't think, in general, the medical oncology and surgical oncology community has taken this seriously enough. So as an OBGYN in our training, it's, in all of our guidelines, it's very clear for women who have premature menopause for other reasons, or we call it premature ovarian insufficiency. It's considered a serious medical condition, and we give them full hormone replacement therapy up to at least the age of natural menopause, because their health risks on every organ system in their body are so significant if they have that premature loss, that we've got guidelines and very important evidence-based statements on how we must take that seriously and monitor her brain health, her heart health, and her bone health, her sexual health, etc., her mental health. But suddenly, when that pink ribbon slips into the diagnosis associated with that premature menopause, it's like all of that stuff kind of goes out the window, and we're just focused on the breast cancer treatment, which is, of course, important, but we've got to focus on, these hard truths. So some of the stuff that I'll say is scary, but I want you to know that I'm not trying to scare you. I want you to know what we can't help a problem or fix a problem unless we name the problem and understand what we're facing, so that we can use the tools to support us to be very healthy, because we can be very healthy even in a premature menopause. So but a couple of basics, so you guys know when you're hearing about this, maybe online or you're thinking about it with your doctor. Natural menopause is when, your ovaries stop producing estrogen. The average age is around 51. And perimenopause can start up to 10 years prior to natural menopause. But most women on this call are not going into natural menopause. Now, some might, and because of their breast cancer history in the past when they were younger, no one wants to touch them with their natural menopause. But many of us have experienced an early menopause that's prior to the age of 45, or premature, which is under 40. And another term is iatrogenic menopause. Get this in your vocabulary, because you bring that back to your doctor and be like, well, actually, I'm concerned about my iatrogenic menopause. Because I've had patients tell me that their doctor said to them, like, well, my menopause wasn't so bad, or, a low carb diet works for me, or, I like to sleep with the window open, and that's been really great. And I just eat a little bit more soy products. Like, that's cool for your natural menopause. But iatrogenic menopause, chemotherapy, surgery induced, medication induced, so medications to shut down your ovaries, Lupron, Zoladex, and then aromatase inhibitors, which then take that very low estrogen state and put it even lower. And then tamoxifen, that is blocking estrogen receptors. So all of those things are iatrogenic. Um, so when we think about what the effects of the loss of not only the estrogen, but if you're not ovulating, you don't make progesterone, and your ovaries also make testosterone. Testosterone is a female hormone, okay? So if you have your ovaries removed in particular, so surgical menopause, we know it cuts your testosterone in half, right? This is often overlooked and not discussed. And testosterone is more than just your sex drive, although it's important for that. But this kind of graphic, there's a lot going on here. And oh, by the way, you guys are going to get a PDF copy of these slides, so you don't have to take any notes. But this image just kind of gives you a full picture that there are estrogen receptors everywhere in your body. And of note, if you have estrogen receptor positive breast cancer, it does not mean that estrogen caused your breast cancer. It does mean that those estrogen receptors are being overexpressed, and we can manipulate those receptors to treat your cancer. But normal, healthy breast tissue has estrogen receptors. the men in your life that you know, they have estrogen receptors on their breasts. But guess what? You've got estrogen receptors on your tongue, on your skin, on your eye, on your gut, on your bones, on your muscles, on your lungs. Every organ in your body has estrogen receptors, right? So I think that's really important for women to understand that ER-positive breast cancer doesn't mean that estrogen caused it, but we can manipulate those receptors to treat it. And then for women who have estrogen receptor negative breast cancer, blocking those estrogen receptors or lowering your estrogen is not part of your treatment. And that's important to keep in mind when we come back and talk about hormone therapy options later on. Um, so menopause symptoms. So a lot of people know, right? Hot flashes and night sweats, but it's more than just that. And there's maybe 30, at least 30 symptoms that we can list and name. Some of them are written here. I want to point out some of the symptoms that like I didn't even realize. I was just a second year OBGYN resident and we didn't get any menopause training in my residency. And I was still a young, resident when I was first diagnosed. And my first symptom was terrible insomnia. I've been a new onset of panic attacks and mood disorders. I was really, from a mood standpoint, doing okay, even though it was obviously a very stressful time. But I had I was not depressed and I felt like I could mentally handle it until chemo started to shut down my ovaries. And out of nowhere, I started getting panic attacks and this horrific insomnia. And of course, I started to have some hot flashes and night sweats. And I had a lot of these other symptoms as well, too. But I didn't even realize it at the time. I think I just wrote it off as, oh, I'm just stressed about breast cancer. Meanwhile, it was the direct impact of that abrupt loss of hormones on my brain chemistry, right? And there was a study a couple years ago, and this was related to perimenopause in the general population, but I wanted to just kind of point it out. The study found that not feeling like myself was the most commonly reported and correlated to other menopause symptoms in this survey of women going through perimenopause. And it really struck a chord with a lot of doctors because that's what patients tell us. They're like, I'm just not feeling like myself anymore. Well, it's because, these vital hormones that you're used to having suddenly, kind of have walked out of the room. So we've got our symptoms, and now I'm going to show you the significant increase in chronic disease risks that happen when we lose our estrogen early. Particularly, these numbers are for below age 40, but certainly below age 45. And this is why if you don't have a contraindication to hormone therapy, this is why we give hormone therapy back. Because we know premature menopause is associated with a higher risk of heart disease, of osteoporosis, of dementia and cognitive disorders, of mood disorders, depression, anxiety, sexual dysfunction, and sleep disorders, just to name a few. So these are showing how there's just a global impact. And it doesn't mean that you're doomed if you can't take HRT, but we have to recognize the elephant in the room and use all our other tools so that we can mitigate these risks. And we can. That's the good news, but we can't if we ignore it. Quick anatomy of a hot flash, like what is it and why does it happen? It's important for you to know, and this explains the new medications that have been FDA approved recently to treat hot flashes. So in your hypothalamus in your brain are these little candy neurons. And when estrogen leaves and it's not getting feedback, they fire away irregularly and frequently to these little NKB neurons, right? And that causes vasomotor symptoms. So VMS, you might hear me use that acronym. And vasomotor symptoms are hot flashes and night sweats, which leads to temperature dysregulation. And there is constriction and vasodilation of these little blood vessels in your brain and in your skin. They can often be associated with palpitations, like little heart palpitations, and feelings of anxiety or discomfort. People often say, I just don't feel like comfortable. And all of a sudden, I'll get a wave of not feeling comfortable in my own skin. They result in insomnia, daytime fatigue, mood changes, brain fog, right? And so I like to show this because if we can treat the hot flash, even if we're not using estrogen, we can really improve all of these symptoms. There's a lot of downstream benefits we get from treating it. So, traditionally, we were only offered things like antidepressants, so the SSRIs. So this is from a paper. You guys are going to get like lots of resources at the end, but this is from the non-hormonal position statement published in 2023. It's a great resource to bring to your doctor. And this has all the evidence-based ways to treat hot flashes and also the things that have shown not to be helpful. Not that they're bad, like look over at the right. Lifestyle, cooling techniques, exercise, yoga, weight loss, right? Like those things are great things to do. I'm not saying those are not great things, but they are not effective for managing vasomotor symptoms. So if somebody tells you this is what you should do, like a fan may make you feel better, but it's not evidence-based management for VMS. So traditionally we had SSRIs, we had medications like gabapentin, or Neurontin is the brand name, and now we have the neurokinin B antagonist. So on the chart there, fezolineant or Veoza, many of you may have heard of that medication, and then the newer one is Lincunit. And that's not on the formal chart is oxybutynin, which is a bladder medication, and it seems to work quite well for hot flashes. So in my practice and in menopause specialists that I know, we've really moved to make Veoza and Lincunit first line because they're specifically working and the FDA approved specifically for the hot flash and night sweats. Personally, I like Lincunit the best because they actually studied it in breast cancer patients on adjuvant endocrine therapy, which is a huge bonus. And it seems to be more superior for sleep. It can make people really sleepy. So sometimes I tell patients start with just one pill, not two, but it doesn't have the same negative downstream side effects that some of the other medications do. Not that they're bad. Gabapentin, for instance, can be super helpful for neuropathy, but can also be very helpful for sleep. Oxybutynin, the bladder medication, can help with urinary urgency and frequency, but we've got better things for that, like vaginal estrogen, which we'll get into. But like there can be some overlap indications for some of these medications. SSRIs, Effexor, citalopram, paroxetine, these medications can help, but they have sexual side effects, and nobody tells patients that SSRIs contribute to bone loss. There are serotonin receptors on your bone. So I've got a breast cancer survivor who's already at risk for osteoporosis and sexual dysfunction. This is why I'm no longer going to the SSRIs as the first line choice for her hot flashes. Um, and the other important thing is to understand that hot flashes and the severity of them are directly associated with heart disease risk, right? So this little graphic here is kind of just looking at like if you put menopause in the center, the earlier age of menopause, is the higher your risk of heart disease is, as well as often more your vasomotor symptoms are worse. Same with the type of menopause. Surgical menopause symptoms are more severe, and we also know your heart risk goes up. Um, the worse your hot flashes are from and are waking you up at night and you're having insomnia or you're having depression. So if those things are happening either independent or because of your symptoms, we see that also associated with increased heart disease risk. So I point this out as this understanding that like hot flashes and night sweats are like a canary in the coal mine. It's like telling your body, like, yes, these are symptoms and you deserve to have them treated, but we have to think of them as like a little bit of a warning that what's happening with these vasomotor symptoms, it's also a sign that you are at a higher risk for heart disease. So getting your symptoms under control is important, and also making sure we're taking care of other aspects of heart health. Um, this is what I ask my breast cancer patients on their intake forms. I want to know the American Heart Association has like a heart disease calculator. It's actually called a the prevent tool. And you can type in your blood pressure and your cholesterol, and it will get you a baseline risk of heart disease. But it doesn't include breast cancer specific things, which it really should. And so I have patients do this checklist. Have they used any of these breast cancer specific medications like Herceptin, radiation? They had premature menopause. Are they on ovarian function suppression? Do they have severe menopausal VMS and insomnia? And do they have depression and anxiety? So the more checks they have, the higher their lifetime risk of heart disease risk is. And this goes along with sleep disturbances. This is probably the next, hot flashes and night sweats, but most patients tell me like if they can just sleep, they could deal with a lot of the other menopausal stuff. And so this is really important. And I just want to say like sleep hygiene alone is not an effective it's not effective enough for true sleep disturbance. Like, yes, we have to have good sleep hygiene, stay off our screens, avoid alcohol at night, avoid, too much like liquids before you go to sleep, etc. But, if you are having really disrupted sleep, you need to talk to your doctor about real evidence-based options. Number one, I want to make sure your hot flashes and night sweats are treated so you're not waking up for that. Cognitive behavioral therapy for insomnia. There's a lot of online apps and some very inexpensive ways that you can access CBT for insomnia. It can be amazing. Up to 60% of breast cancer survivors, particularly due to hormonal changes that cause tissue structural changes in your neck, can get obstructive sleep apnea for the first time in their lives. So get a sleep study and rule out sleep apnea. We need to lean into the lifestyle medicine pillars, but like sleeping pills, or taking a Benadryl or, trazodone or these medications, they can be helpful. They're really not first line. And then we're going to come later on what the genitourinary syndrome of the menopause is. But getting up to pee a lot at night is one of the symptoms, and we can treat it with vaginal estrogen, and it actually helps your sleep because you don't wake up in the middle of the night to have to go to the bathroom. So that's a little something to also think about. Now, moving from sleep, kind of, well, sleep is part of your brain function, of course, but brain health and the neurologic implications of premature menopause, it's important for us to discuss. Estrogen's a master regulator of women's brain health. When you understand that there are receptors in your brain to estrogen, progesterone, testosterone, you can understand that some of the mood changes, the anxiety, the depression, brain fog, yes, there's many factors associated with it, but that menopause can really be driving it. And I'm tired of people telling patients, oh, it's chemo brain, or patients like 5 years into their adjuvant endocrine therapy when chemo's way behind them. They're like, oh, it's my chemo brain. I'm like, no, it's not. It's not. I mean, I'm not writing off that chemotherapy can't cause cognitive impairment changes, but it's particularly when you're on it and in the shorter term. But for the long term, the major cause is chemotherapy induced premature menopause. It's the lack of the hormone. So I think it's really important that we tell women what they're actually experiencing and not just tell them it's chemo brain. Because guess what? Chemo brain is hard to fix, but treating the cognitive changes for premature menopause, we actually have tools for that. Treating the sleep disorder, treating the hot flashes, the pillars of lifestyle medicine, screening for anxiety and depression is super important because that can be like brain fog, but it's actually anxiety and depression that may need to be treated with medications and therapy. And then this idea, a lot of women tell me, they're like, Dr. Men, I'm so afraid of dementia when I get older. I'm losing my estrogen. And I remind them that, yes, we would love to give you HRT, and not everybody who's a breast cancer survivor can get it. But if you have very good cardiac health, and if you're exercising and strength training and having good nutrition, your heart health and your vascular health is directly related to your brain health because your blood flow and your cardiovascular function in your brain is the key to preventing dementia in the long term. So now let's move into osteoporosis. You all, I hope, know that if you are young and experiencing earlier menopause and you're on some of these medications, whether it was chemotherapy or your other endocrine therapies, you are at higher risk significantly for osteoporosis. Very few breast cancer patients are getting appropriately screened, in my opinion. So I want you to make sure if you're new to this menopause diagnosis, get a baseline, even if you're still not menopausal yet. I want to know what your baseline is before you go down the road of, medication or surgically induced menopause. Tamoxifen is not protective. I can't tell you how many patients are told by their doctors that tamoxifen protects your bones. It does not if you're premenopausal. If you're 65 years old and you get tamoxifen, it's a weak agonist or a weak, um, uh, you know, um, promoter of the estrogen receptor in bones, but not when you're young. When you're young and you still have estrogen being produced from your ovaries, it competes with that estrogen. And if you're young and you're put on ovarian function suppression, that's an artificial menopause. The tamoxifen is not protective there. And so I see a lot of patients who were never put into menopause. They just took their tamoxifen and they find out at age, 45 that they already have osteoporosis. They're like, my doctor never did a bone density on me because he said tamoxifan's protective. It's a real misconception, particularly among oncology professionals, unfortunately. So be a squeaky wheel about this and demand a baseline bone density. If your insurance doesn't cover it, it only costs about $100 cash pay to get it. So that should not, you should try not to let that be a barrier. But if it's properly coded for your premature menopause or your medications, it should be covered by your insurance. And we have very directed ways that we can treat low bone density and prevent you from getting osteoporosis. So that's why we want to catch it early so that we can manage it down the road. Um, Another part of bone and muscle health that we have to think about in menopause is the musculoskeletal syndrome of menopause. So that is joint pain, frozen shoulder, muscle loss. We call that sarcopenia and joint stiffness. And there's a particular form of this called the aromatase inhibitor musculoskeletal syndrome. And that's really a menopausal syndrome from that very severe loss of estrogen at the joints. It's because estrogen promotes collagen production as well as blood flow, joint lubrication, and keeps estrogens responsible for the really integrity of that joint. So when it leaves, as well as testosterone, when that leaves or is lowered, we get a lot of these symptoms, and we have to really kind of address it. We have to get ahead of it because these symptoms, can be progressive. So I wish patients were informed of this early because the most important thing we can do early on is weight-bearing exercises, strength training, and moving, because moving is like helps give more lubrication and more blood flow to the joints to keep them healthy. If you are in a place where your aromatase inhibitors or your medications that you're on are causing such severe, pain, and you've tried to switch your different aromatase inhibitor formulations, or you've even tried tamoxifen, this is where sometimes I've worked with patients to pause, take a brief drug holiday, come off their medications, then but do their drug holiday in a way that is purposeful. So they're saying, I'm taking 2 months off, and in those 2 months, I'm going to work with a personal trainer or physical therapist. I'm going to work on an anti-inflammatory diet and my nutrition. And then you can restart your endocrine therapy because for some patients, it's gotten so difficult that it's very, very hard for them to get to the gym or do these other things, that really is very, very important for preventing what we call this musculoskeletal syndrome. But to quickly touch on weight and metabolic changes, a big common complaint for breast cancer patients, this is menopause related. So we know age can cause weight. We know there are other lifestyle factors, but we have to be honest with young women that when we drop their estrogen levels, we increase visceral fat around our organs, which is very inflammatory and interferes with insulin metabolism. It interferes with our basal metabolic rate. When we're also, and we can also lose some lean muscle when we are losing estrogen. And also, we might not be as active because we're dealing with treatment, et cetera. And tamoxifen and aromatase inhibitors, in addition, have direct negative metabolic impacts on our liver and our metabolic health, right? And those things, of course, increase our cardiovascular disease risk. And we know weight gain and obesity make breast cancer outcomes worse, right? So I think, we all know lifestyle, Mediterranean diet, you're going to hear that over and over again. But I really think that the GLP-1 medications, I'm seeing more and more used in a more proactive manner to help patients get ahead of things. And I find a lot of patients, even their very significant menopausal symptoms like their musculoskeletal, their joint pain, sometimes their sleep, just losing a little bit of weight, helping them get back to their healthy weight zone can be really, really helpful. And we have, promising data now in the breast cancer space on this. On the right is a list of some basic metabolic labs. I think it's really important for breast cancer patients to keep an eye on. We want to know your fasting glucose, your fasting insulin, your hemoglobin A1C. These are all markers of glucose metabolism, expanded lipid profiles, a more enhanced cardiac profile. And Get a body composition DEXA where it's looking not just at your bone density, but your visceral fat, your lean muscle mass. And it's an important thing that you can do and follow things. And it really can really help motivate and direct patients in their lifestyle, medicine, their exercise, and their nutrition, and can be really, really helpful for getting, reining in the menopausal side effects that, are affecting your metabolic health. Save the best for almost last is the genitourinary syndrome of menopause and sexual dysfunction, not because it's the best, but because we've got really easy tools to treat it. And I want you to feel really knowledgeable and comfortable on how you can treat the GSM. So I'll just use that, the shorthand. So we call it this syndrome because it's not just dryness. It's genital external symptoms on the vulva, the vagina, which could be burning, dryness, irritation. It's sexual symptoms like less lubrication, pain, and impaired function because the tissues are getting thinner and atrophic, including the clitoris, including the labia. So um, that's one part of it. And then urinary symptoms. So urgency, frequency, UTIs. ER visits for UTIs is one of the most common ER visits for a breast cancer patient. I've had patients have to pause treatment because they had so many UTIs because no one was taking care of their GSM. So I've got a bunch of slides on this. This was a great paper recently published showing where they documented exactly all of the anatomical changes that are happening on the outside and on the inside. And they were very high. All of these different changes, atrophy, shortening of the vaginal length, loss of the vascular, blood flow to the inner vagina and the outer vagina, or the outer labia and vulva. And so, when a doctor says, well, you can use some lubricant and some moisturizer, well, I'm going to tell you, those things are comfort measures, can definitely help with symptoms, but they're not treating this anatomic atrophy. So here, when you look at this picture, like on the right, I think is the better image. So you see before menopause and after menopause, and it's showing you the vaginal canal, right? So you just have to remember what's happening there is also happening on the outside labia, and it's also happening inside your bladder. So think about all of those things. This picture is just showing that inner, inside the vaginal wall. So they were elastic, they had lots of blood flow, they were thick, they were moist. The integrity of the structure was good. And then with the loss of estrogen and testosterone, it makes things, thinner, loss of blood flow, loss of sensation. This is like my favorite picture of all time, so I always sneak this into my slideshows. So your clitoris, which you only see the little tip of it outside, but everything else is buried underneath the labial skin, and it's very vascular, right? And look at anatomically, it is a homologue of the penis, right? And so, could you imagine if we had all these millions of young men whose penises were shrinking and atrophied, and we said, why don't you use a little coconut oil and see how that goes, right? No, it wouldn't fix it because it's not going to fix blood flow and structure and collagen and sensitivity. So sexual dysfunction and low desire are associated with this loss of kind of blood flow and tissue function. And so vaginal estrogen is like Viagra for the female, and it's extremely safe for our breast cancer survivors. And we're going to talk about that in one more slide. But I also want to point this out that if you have had breast cancer treatments and you are having problems with orgasm and sexual function, it's really important for you to go to see a specialist and get a proper external exam. This study showed that 65% of patients who went to a sexual health clinic because they were having orgasmic dysfunction and low libido were found to have adhesions. So basically, a little kind of bit of scarring and tissue over the head of the clitoris because of the skin being so atrophied and thin. The good news is little vaginal estrogen can fix that, and we can actually break up the adhesions and expose the little tip of the clitoris. And this is an important thing for you to understand because moisturizers and lubricants are not treating this, right? So we can't let young women, just be sent off with those as solutions. We love these as adjuncts. So know the difference. A lubricant helps with friction, right? Makes things slippery. Moisturizers are temporary relief, right? So it brings a little moisture to your skin and your face, or moisture down to the vagina and the vulva. So we love using these, and you should use these upfront regularly all the time. Lubricants are good whether you're with a partner or with yourself. Any friction is not going to make your brain want sex, right? So that's part of like improving libido is making sure it doesn't hurt down there. But vaginal hormones are safe and effective. This is like my favorite thing to talk about. We've got major society position statements from every single medical society that deals with this, from the American Society of Clinical Oncology, the OBGYN Society, et cetera. Including in estrogen receptor positive patients. We've got meta-analysis looking at tens of thousands of women showing actually those who use vaginal estrogen have a lower risk of recurrence and a lower mortality rate. We don't know why, and these are observational studies, but it may mean that they're able to stay on their adjuvant endocrine therapy. So perhaps they have even better outcomes. Just a quick picture to show you there's tons of guidelines, and every few months we've got another study going out supporting this. And then I just have to like pop in and say, if you're on an aromatase inhibitor and someone says, but what about that Danish study? The Danish study was a super crappy study that is being used to withhold vaginal hormones from some women on aromatase inhibitors. Because in a subset of the study, it showed that women on aromatase inhibitors had a slightly higher risk of recurrence if they used vaginal hormones. But it was a retrospective study looking at patients from 1992 to 2004, before we had oncotypes, before we had Herceptin. Very few patients were on AI. So the ones who were on AIs were already really high risk. They were using outdated formulas. And there is no other data point on earth that suggests a higher risk of recurrence or mortality with aromatase inhibitors. So this one poor study should not be used to withhold that from you as an option. So much that the Menopause Society, sent out a very important first to know alert to all menopause providers, and some very important physicians, including Sherry Goldfarb, who's at Memorial Sloan Kettering, wrote a whole editorial back saying why that study was such a problem. So my personal perspective is we are hurting patients by telling them that they first must wait to have severe symptoms before starting vaginal hormones. So I'm going to speed through these because I know I'm getting a little over time here. We need to do vaginal hormones up front. We need to educate women about the genitourinary syndrome menopause. We need to talk about arousal and vibration and lube and moisturizers. Um, Quick little picture of topical estrogen. You want to use it on the outside, not just on the inside. So those yellow areas are where you want to apply a little bit, and 2 or 3 times a week can do the trick. Vibration for pelvic health increases blood flow, and yes, it's a medical device. I'm going to skip through some of these. I just want to mention systemic hormone therapy after breast cancer. More and more people are talking about it. This is me at Harvard this past winter with 3 very respected medical oncologists. We all agreed that menopausal hormone therapy after breast cancer should be personalized, not outright prohibited. British Menopause Society, the Menopause Society, both agree. There was recently a practice pearl on this that says it's antithetical to the absolute ban on hormone therapy is antithetical to the current oncologic approach to interrupting endocrine therapy in patients with early stage breast cancer to have a baby or breastfeed. So you can pause your tamoxifen or an AI to have a baby. But once you're done with all of your breast cancer treatments, you can't consider using hormone therapy if you have severe menopause symptoms or are in premature menopause. It doesn't make sense that we value hormones in one area, but not for the suffering of someone who is dealing with severe menopausal symptoms. Um, and so I'll direct you, you'll have all these resources. This is a very important paper that was written, Menopausal Hormone Therapy for Breast Cancer Patients. What is the current evidence? It divides up different categories of lower risk, triple negative patients, ER negative patients, and then higher risk for recurrence hormone receptor positive breast cancer. And basically everything is about the type of hormone, the formulation, how severe your symptoms are, and your stage and your type of breast cancer, because none of our breast cancers are the same. We can't treat a DCIS who has had bilateral mastectomy the same as someone who is a stage 3 ER positive patient versus a triple negative patient who is now 6 years or 7 years into her diagnosis and maybe now has had her ovaries removed for BRCA, but not to treat her breast cancer. So, we can't treat all of these patients the same when we're talking about systemic hormones. Really important. So I'm going to skip because I know I'm going over, but I want to point out we've got a study coming up. I want you to all participate so you can scan this and you will be sent a survey about your menopause experience. And then hopefully in a year or so, they're going to have a study on hormone therapy in breast cancer survivors. And even if you choose not to ever take hormone therapy, you can participate in the study. So please check that out. My favorite place for support is menopauseandcancer.org. This is my favorite book for lifestyle medicine help during menopause for breast cancer survivors. This is a young survivor who is part of the YSC. You should follow her, Dr. Carolyn Cook. She's an expert in lifestyle medicine and managing menopause. Dr. Toplinsky is an amazing medical oncologist who does a lot of work in this, and we do a co-substack once a month together on menopause and cancer. And this is another QR code on vaginal hormones. And if you've got any questions, you can reach out to me. And I hope this will still be your best era yet, because we can really live well with our premature menopause. And that's that. And I'll go back and I'll leave the QR code up. And if we've got some time, I'm happy to take some questions.
Perfect. Dr. Ben, I just want to mention, it says in the chat, one of the QR codes is showing deactivated. I believe it was the first one.
Okay, so I'll make sure that whatever I can fix that, and then when you send out that PDF, I'll make sure that it's it's correct.
Perfect. Okay. Thank you so much for all of your information, Dr. Min, and for the empowering presentation. On behalf of everyone at Young Survival Coalition, we truly appreciate you sharing your expertise and helping us better understand and navigate menopause after breast cancer. I know that I'm not the only one who learned something new today. While we're going to transition into our Q&A, we'll give everyone just a moment to submit any questions they may have. If something came to mind during the presentation, or if you'd like Dr. Min to expand on a topic, we'd love to hear from you. Please use the chat feature to drop in your questions, and we'll get to as many as time allows. And like Dr. Min mentioned, don't worry about taking notes. We'll be sharing her slides and additional resources with all attendees after today's event. So you'll have an opportunity to revisit the information and explore the recommended resources at your own pace. I'm going to give everyone just a few moments, but I'll go ahead and kick off the questions with some that came in during your presentation. Um, First question, how do you know you're really in menopause? My period stopped during chemo and hasn't come back. I've been done with chemo since 2025. I'm triple negative, but with a tiny estrogen positive, so I'm on tamoxifen. I was diagnosed at 38, and now I'm 40. My period hasn't come back.
It's a really important question. And so important to note that tamoxifen does not put you into menopause. It does not accelerate your menopause, but tamoxifen is known to cause amenorrhea or lack of periods because it interferes with some of the signals for you to ovulate. So in order to test to do a blood test to check an FSH and an estradiol, you really can't be on the tamoxifen or certainly not on the aromatase inhibitor. So the only way to truly know is to actually have a little bit of a washout period. Normally, we like at least 6 weeks off, and then you could check an FSH and an estradiol level. But I will say that we know that women who have had chemotherapy are likely to go through an earlier menopause, even if their periods return at some point in time. They're just more likely. And then the other thing is that, even if you're not menopausal, perimenopause can start 5 to 10 years before your periods totally stop. And so for a lot of women who had chemo, it's the perimenopausal symptoms that are really getting them. And I've had a lot of, say, triple negative patients who are not on tamoxifen have a lot of symptoms. And their doctor says, well, you're still getting periods, so it can't possibly be perimenopause. You're too young. But that's not true because if you are destined to have your period end at, say, 51, but you had chemo, so now you're probably more destined to have it at like 46. And so 10 years before 46 is, 36. So it wouldn't be outlandish at 37 to start having perimenopausal symptoms, which can happen even if you're getting a period. So kind of a long, complicated answer, but hopefully it gives you a little bit more insight into that. And so so if you're having menopausal symptoms or perimenopausal symptoms, you don't need for it to be proven that you're already fully menopausal. You can use all the tools that we talked about to help get treatment. And whatever questions we don't get to, I'll have the YSC send it to me and I'll answer them on my Instagram stories this weekend. So I promise I'll answer every question that the YSC sends me, even if we don't get it to tonight. So just you have to follow my stories.
Perfect. Thank you so much for that. Can you
Yeah.
clarify the premature menopause definition again?
Yep. It's anybody who has menopause prior to the age of 40 and under.
Is there any link between latrogenic menopause and I believe they meant lymphedema, but I'm not going
No,
to.
not that I know of, but I do think that the changes that are happening in your body from premature menopause, like the musculoskeletal changes, the metabolic changes, weight gain, etc., I think it can exacerbate lymphedema for sure. Just my clinical opinion. I don't think we have data on that.
Who should be leading the treatment plan for menopause effects from cancer treatment?
Okay, this is a good one. This is my activist question. Who should be leading it? The leading cancer centers in our country. Okay, because this is where I want you to get fired up. Because if you went in for an amputation of your leg, I'm being facetious here, but kind of not, and they sent you home and just said, figure it out. Like, like maybe you had a tumor on your leg and you had to lose your leg. Would we just send you home without help, support, a wheelchair, or crutches to help you with this new normal? No. If you had a side effect or a complication from heart surgery, would they just be like, well, I do the heart surgery, but I don't really deal with the complications of heart surgery. Like, you'll have to find somebody else. That's not cool. Okay. If you are prescribing a medication or doing a surgery that puts a woman into early menopause or induces severe estrogen deprivation, it's your job to either fix it, have evidence-based options, or if you're not trained, because let's be honest, OBGYNs were not trained during their residencies. Medical oncologists have zero training, zero in managing menopause. They're trained in lots of other things. I don't blame them. But there's an ethical and medical duty from not only the medical oncologist, but the cancer center, these famous cancer centers around the country. They have an ethical and medical duty to have a place to refer patients to. Because what happens is patients are like, well, I'm going to go see my OBGYN. They see the OBGYN, the OBGYN's like, well, I don't really do menopause. And you had breast cancer, so I don't know how to do menopause after breast cancer. And they're like, go see the endocrinologist, the hormone doctor. Well, the endocrinologists in general have no menopause training. They treat other hormonal things like thyroid disorder. And so patients get bounced around. And then we wonder why patients wind up with sometimes doctors who are not doing evidence-based medicine, or they go to all sorts of practitioners or buy all sorts of concoctions and supplements and sometimes dangerous things online. So I think, oh, urologist. Now, a urologist might be able to deal with the genitourinary syndrome of menopause, but not, I'd say at least 50% of the time, the urologists are not up to date on the safe use of vaginal hormones. And they're putting patients on bladder medications when they're having recurrent UTIs. When guess what decreases UTIs by 50%? Vaginal estrogen. So this is my little rant that you guys should also be fired up and expect a little pushback sometimes from your doctors, but your job is to say, no, it's your duty to give me evidence-based medicine for my collateral damages of the treatments that you're causing. I get it, doctor, if you don't know what to do about this, but you need to help me find somebody who you can refer who is practicing evidence-based medicine. And I shouldn't have to wait 9 months to get into the sexual medicine clinic at your hospital for something that is affecting me right now. Like I can't sleep, I have joint pains, I have mood disorders, I have horrific hot flashes. So I think it's that's my activist rant. I'm sorry, I get very upset about it because it's really a problem.
We definitely appreciate your passion. I feel like it's getting everybody else fired up too. Um,
The
how
UTI
do
thing, I can't. I just can't with the UTI thing. Okay. I'm going to say this also. Um, there was just a very important paper published in the general menopause population showing that vaginal hormones reduced the risk of urosepsis, death, and ICU admissions by 80%. Vaginal estrogen saves lives. I was on stage last fall and a breast cancer patient who's being seen from a very famous center in New York City. She had triple negative breast cancer. Chemo caused her menopause, not estrogen blockers. She had to stop chemo for 3 months. Have you ever heard of a triple negative patient stopping chemo for 3 months? Like that's their mainstay of treatment. Why? Because she had so many ER visits for UTIs until finally someone says, wait, maybe it's GSM, vaginal estrogen. And 6 weeks later, she never had a UTI again and she was able to start her treatment. To me, that's medical negligence. And I see it happening constantly with patients. Can you tell
Thank
I'm
you for
mad?
that. I can definitely tell you're mad. I
Yeah,
feel
a
like we
little
should all
mad.
be mad.
You should be mad. Well, because the squeaky wheel is here and you advocating for yourself, you're going to help the young woman who comes behind you. But the good news is like this is being talked about in the mainstream media. Yesterday, my friend Kelly Casperson, Dr. Kelly Casperson, you have to follow her on Instagram. Oprah Daily published an article saying that menopause or like breast cancer survivors should not be left out of menopause, and that, yeah, they can talk about hormones in different ways. Local vaginal hormones. We didn't even get into testosterone. I'll come back another time and talk about that. And there are some women who might choose systemic hormone therapy. Yeah, men would never put up with this. You're right. I'm reading the comments here. I get a little face.
I am too. Like the comments are coming in fast and furious, and just I'm appreciating all of this.
So
Let's
now,
see.
and I'll also say, like, I think if you are new to treatment, I think that patients should upfront be offered the vaginal hormone before the GSM starts. I think they should have a list of prescriptions that they can be on the ready to start for their hot flashes and night sweats. I'm very, very proactive at starting Lincunit with a vaginal hormone. And we didn't get into all the different vaginal hormones, but there's creams, there's inserts, there's rings, there's lots of different ways to deliver the vaginal hormones.
Any thoughts on vaginal rejuvenation treatments?
Great question. So, sham controlled studies where they basically do the there's lasers, there's a couple different modalities compared to basically a placebo or like a sham have not shown in the small studies that have been done a benefit. That being said, I have seen in clinical practice, I never use it in my practice, but there are, I think, in very, very good hands, it can be helpful for some genitourinary symptoms, not the urinary symptoms. It can be helpful a bit for lubrication and improving the tissue quality. But the problem is that it's a temporary solution that's quite expensive, does have side effects. People who are very estrogen deprived, particularly the women on aromatase inhibitors, where they're like afraid to use vaginal hormones or they're being, refused vaginal hormones, are referred to these lasers. And the problem there is they are so atrophic. The skin is so thin that if it's done in someone who the doctor using the laser, if they're not very skilled or careful and use a lower setting, I've seen patients have labial burns and scarring and damage because a laser is really relying on your body's own immune system and really function to like regenerate and have collagen build up. But it's very hard to do that in tissue that is so estrogen deprived and thin. It's like, estrogen is an important building block for collagen production and blood flow and stuff. So when you're really deficient, I think you have to be careful. I think it's best reserved for someone who is already using vaginal hormones and then you're using it as an additive. But you also have to go back yearly for boosts. It can cost up to $1,000 a treatment. I think it's just simply not necessary for the vast majority of women, and it does nothing to prevent UTIs.
Okay. Thank you again so much, Dr. Min,
You're welcome.
for your time and your talent. We are gonna unfortunately wrap up the
Yes, that's
Q&A
fine.
portion.
Of course.
Um, well, I'd love to end on this one if you are willing to take one more
Sure.
question. What gives you hope when you think about the future of menopause care for young breast cancer
Oh,
survivors?
I have a lot of hope because honestly, the menopause movement and the regular woman space is trickling down, and it's trickling down really, it's starting to pour now because of social media and people getting out there speaking. And when Oprah Daily is covering breast cancer and menopause, Maria Shriver just wrote a big post on it. The New York Times wrote about it. Like the cancer centers can't hide from it anymore. I see change is coming from the bottom up. It's like a grassroots. Women are coming and being like, "Hey, like what about me?" And so I think that's really promising. And there is interest in the medical oncology world to start to study and really understand that if we are valuing pregnancy after breast cancer, which is filled with hormones, why can't we value the quality of life on a woman when her reproductive capacity is no longer her priority? They let me stop tamoxifen 23 years ago to pause to get pregnant. But when I was done with 10 years of tamoxifen, after suffering for so many years with menopause, no one did anything for me besides an Ambien prescription. That is changing now. So please participate in the Meno ABC trial. I've got links to it on my social media. A survey is going to go out this fall about your experience in menopause. That's the preliminary part of the study. So I really am encouraging all of you to spread the word and get women involved in this study. I'm going to post about it tomorrow. So, and it's there in my bio. So check it out. Thank you for having me. And please, YSC, send me the list of questions. You'll give me my content for this weekend for my stories. I love it. Okay, ladies, you guys have a great night and enjoy the our next upcoming speakers. Thank you for having me.
Thank you
Thank
so
you.
much, Dr. Mann. All right,
Thank you
everybody.
again. Got it.
All right, everyone, we're going to move into our next session. Those of you who don't know me, my name is Kendall Johnson, and I'm YSC's NBC Thrive Program Associate. So we're going to get into a little bit of a community highlight. We have a fantastic couple up next, Joe and Allegra. So Allegra was diagnosed with breast cancer at age 39, and what came next was not the tidy bow on top version of survivorship. It was fear, grief, tenderness, uncertainty, and a fair amount of laughter in the wrong places. In the middle of chemo, Joe proposed. 2 years later, the two of them sold nearly everything they owned, drove 2,300 miles to Durham, North Carolina, a city and state where they'd never been, so Allegra could get the access to the care that she needed. Along the way, they learned that survivorship is not only about getting through treatment, it's about staying a couple and staying themselves while body, identity, intimacy, plans, finances, and roles are all changing at once. Today, they are building a life together in Durham and sharing their story and hope that other individuals and partners feel less alone in the messy, honest, difficult, and sometimes unexpected, funny realities of life during and after cancer. So I'm happy to introduce Joe and Allegra.
Thank you, Ken. I don't know what to
That
say.
was amazing, Kendall. Thank you. It's,
Of
I mean, a
course.
hard act to follow, but here we are. So I thought to maybe open this by asking everyone a question. Has anyone in this room been so mad at cancer that you took it out on the person you love? Okay. And has anybody ever written a manifesto at 2 a.m.? Yes. All right. That was me. And fear made me do some crazy things.
And my name's Joe, and I've woken up to several manifestos over coffee in the morning, and it's quite an experience to have your morning read be something that was typed out at 3 a.m.
Yes.
or 2 a.m.
Yeah.
I'd hate to get this wrong.
Hate to breathe wrong. But here's what we figured out later. The manifestos were just one tip of the iceberg. And there was something that I never said. And today, I think what our hope is to share about how we got here and what keeps us going as we move forward living as a couple with cancer.
Yeah. And I also think too, every coupleship meets cancer differently, and everyone's coming to this Zoom meeting and this meeting place in a different stage. And so we're here to share about our experience, what we've learned through the journey, and hopefully something, maybe a tip or trick or two that we've picked up as well.
All right, so real quick facts. Diagnosed 39. Stage 2B ended up being stage 3. Genetic mutation that my family hid from me. Hormone positive. 7 lymph nodes tested positive. And I thought that I would be done when I rang the bell. And that didn't happen. Instead, I was told about this cancer via phone call and immediately told Joe, I have breast cancer, and the doctor told me to Google it.
I think at the start of the journey, yeah, I was in the garage working out with our German Shepherd, who's right to the right. Allegra came through the garage door with the worst news we'd ever gotten, and that just started the journey. I'm like, well, what did the doctor tell you to do? And she said, Google it. And I was like, you gotta be fucking kidding me. Excuse my French, but I'm guessing we're all adults here. I've Anyway, what we didn't know then, because as soon as we started Googling it, we identified the major treatments. There was the chemotherapy, there was the double mastectomy. Allegra was lucky enough to get reconstruction done during all-in-one surgery, then the radiation. There was an 11-month treatment plan, and we thought if we get through these 11 months, we're going to be okay. These 11 months, we can make it through this. We had these major hurdles, we had these targets, we had a purpose, we had a mission. We researched the hell out of everything. And what no one told us is it's not a sprint. The getting through the major treatments and ringing the bell is the first step to the hereafter and the next 10 years or more that comes. We're starting an ultra marathon. And so when we finished that first year, we thought we're going to get our old life back. And nothing was further from the truth.
No, nothing. And I think breast cancer has a way of like waking up those fears. And mine sounded like, all right, now I'm becoming too much. And Joe never had given me a reason to think that he was leaving, but my fear didn't wait for evidence. So instead of saying, I'm scared, I said, I'm fine. And I thought it was because I was protecting him. And I was actually protecting myself and my own fear.
Well, and then so I'm waking up to these manifestos, and they're, on a good day, one page, on a, really good long reading day, they might be 8 or 9 pages long. And I took them personally at first. And what I didn't realize was that those writings were driven by fear. They were driven by the cancer. They were unloading the fear that had no other place to go. And as we started going through this journey, and especially after we finished the major treatments, it became really apparent to me that I'm leaning in, trying to figure out what's going on. How do I make this better? Because I love Allegra with all my heart, and I couldn't. But she's pulling back from fear and silence. I'm leaning in with fear, and I'm asking all the wrong questions and doing all the typical things of how do I fix this? How do I make it better? And full disclosure, I've been a drug and alcohol interventionist for 20 years. And the things I teach families is you can't fix someone else's disease. You can't make things better for someone. And I didn't even take that on my own, what I professionally do. And that caused me to take it personally. And that was, I think, the low point in our relationship. When we're both sitting in fear and getting more isolated and more distant as we're traveling the same road.
Yeah, I mean, it's a pretty lonely place. So I guess I have a question because clearly I'm the only one that writes manifestos. But if there's some version of that storyline or silence that lives inside your house too, you don't have to explain it or like give it the whole story. Just type the word here in the chat, and that's all. I love seeing some of the things pop up. There you
Oh,
go.
thank God. Keep typing.
Oh my God.
We were hoping to see that one.
Yeah. Phew.
Because one of the most challenging things I went through, and maybe I can't speak for you, but I'll speak for myself, was thinking like it's just me. What I'm experiencing, who do I turn to? I have a lot of support with a lot of good men friends back in our old home in Palm Springs. Uh, but the reality was most people don't get this disease. They don't get how to support it. They have good hearts and they have good intentions, but the questions, the words, the um, for me being in a room with men, partners, spouses, I get to be a part of the YSC Men's Co-Survivor meeting on Tuesday night, on the last Tuesday of the month, coming up soon, guys. Being in a room with men that have walked that road, there's nothing like it because I don't have to explain. I don't have to give a backstory. I can just be, and people get it. And that type of community is an amazing experience.
Yeah, well, so full disclosure, he totally got it from me. And I see some of my ladies here from YSC Wigwam because my cancer came with grief and the grief that never came with a warning. And for a while, grief was like my operating system. And then I found YSC and then I went to the Wigwam in Arizona. And it was the first place where I didn't have to explain all of the hard parts. Like what you're seeing in this like Zoom chat right now is exactly the thing that saved me. And because it took me so long to understand that I'm not too much, and that's not the right question. I was never too much. The load has been so heavy, and those are two totally different things. And whether someone can carry that load with you says everything about their capacity and nothing about your worth.
But even I couldn't carry that load too, because when you came home from a wigwam and you'd gone with another friend from the desert and they had been planning the outfits, the rollers, she goes, "Can I get roller skates to go roller skating with all the medical treatments?" I was like, "Are you trying not to be controlling?" I'm like, "Hell no, no roller skating at the wigwam. Okay, I love you, but your coordination skates, it scared the hell out of me." But when she got home, she just bounced out of the car. Like it had been the most amazing experience. And part of it's a plug for YSC, but it's really speaks to community and being with people and getting connected. So you don't have to give the backstory. You can walk in, be seen, and be understood. And that's maybe the biggest thing because I'm not in your shoes, and the diagnosis happened to our relationship. We both carry the fear, and at the same time, it's different sides of the fear. And this is a little embarrassing, but in preparing for this talk, we've actually connected and shared things that we hadn't before and named some things. And this preparation forced us to step into even more honest conversation. And so for that, I know I'm grateful. I think we're grateful.
I guess I'm grateful. I don't know. I'm having a menopause moment. Just kidding. I'm so grateful. And no,
It's
really,
nothing chocolate won't fix later.
no, but I think, we have our tools too that have helped. And
Yes.
I think one of the tools we have is this like reset, and you can do it with anyone because I just got so sick of like having to explain it all and like make excuses. And so, really, it's just one, I name the state without blame. Like, I'm scared and you're not the enemy. And then,
Always good to hear.
yeah, and then together,
And then I come in, it's not trying to read her mind. It's just, what do you need from me right now? And so I'm not making assumptions. I'm not coming in to fix, make better. I'm coming in just to be present.
and the third is I just say what I need. Like, I don't need to be fixed. I just need to be angry. And if possible, I would really like some ice cream. Thank you. Good night. And it really works because he's not trying to read my mind. And no offense, you're a horrible mind reader.
Confirmed, I am really bad. It's horrible. I can get it wrong 10 out of 10 times. But the point is this, I stopped coming in like a bulldozer trying to figure out. And it was my fear and my inadequacies and my insecurities about what I was doing and how I was doing it because this cancer thing, it wreaked havoc on every aspect of our life, including finances. And as a man, it can be really hard to want to do everything and have limits. And so this was the part of you tell me what you need because then I know I can do it.
Right. And it's just, I think, too, understanding that capacity. And especially cancer has asked so much of all of us here. Like the type of truth that is so hard to say that we're saying tonight, and the type of bravery when we don't want to feel brave, and the type of faith that's kind of available to all of us, like faith in each other and in the next right choice. And it asked us to redefine recovery. And recovery for us isn't getting our old lives back. It's learning to coexist with cancer. It gets to come on the trip like it did this past weekend, third wheel, ideally in the trunk, but girlfriend was fucking third wheel in it today or this past weekend. But she no longer gets to drive. And breast cancer, it doesn't get to hijack the whole trip. And it's me learning to embrace all 6'7" of you, Joe. And instead of holding back to protect us from the future we're both afraid of.
And I think cancer also had us redefine what recovery from that means because it changed everything in our relationship. And instead of fighting it and trying to pretend like we're getting back to an old normal, it's embracing where we're going today. And honestly, we don't know. It's this is a work in progress. We're basically 2.5 years into this whole journey, and we're a work in progress. We're moving forward with it. And the one thing we can do is keep committing to not letting fear or the cancer, drive the car.
Yeah, I like that a lot. We have a lot more fun when it's, again, in the trunk or in the back seat. So I guess before you log off, try one honest sentence with your person tonight or text away. 4 words is enough. It's not just us because your relationship isn't failing. You're responding to an extraordinary circumstance and you can learn to navigate it together.
Yeah. Please, let's talk. If there's any questions, we'll share anything that we can.
Thank you both. I love y'all's relationship. Y'all are just so cute. And y'all got a lot of love in the chat. So please go back and read some of the things that everyone is saying. But we are running a little behind. So if there are any questions, please drop them in the chat and hopefully we can get to them in a little bit. But we're going to move on to our next section. But thank you both so, so much for sharing a little bit about your story.
Thank you.
All right, everybody, we're going to move into our next session. It's a little bit of our wellness activity, a little bit of narrative therapy. So next up, we have Mattia Dade, I believe. I don't want to say your name wrong, so please correct me. Let me unpin everybody.
Hello.
Mattia, how are ya?
Hi. It's pronounced Matea.
Mattia, thank you, please.
Hello.
Well, I'm going to give you a formal introduction. So Matea is a triple negative breast cancer survivor. She uses her voice to spark conversation around survivorship wellness and the intersections of identity and healing. She is the host of You Survived, Now What? A podcast exploring the unfiltered realities of life after cancer, mixing it with wisdom and real talk to support fellow survivors navigating their what now moments. As a speaker, she engages audiences with candid insights on resilience, health equity, and the complexities of rebuilding after life-changing experiences. Her love for movement fuels her creative expression, whether she's on stage, behind the mic, or shaping cultural conversations. She moves through every space with intention, originality, and an unwavering commitment to helping others. We are very happy to welcome you here, and the floor is now yours.
Oh, wow. That's an intro, girl. Dang. Hi. Well, I'm Matea, and I do have a resource called You Survive Now What? It lives primarily on social right now, being evolved into a pod. Um, and yeah, it's really about like getting our lives together and figuring out what are we doing now because we're in our prime. And I feel like, at least for me, coming out of a period where there was a lot of agency lost, I've been grasping for straws to try to find a way to rebuild my life in a way that looks better and more sustainable to the version of me that I am now than who I was before, because that girl is gone. We don't know her anymore. And I'm sure a lot of you can relate. So, with that in mind, everyone's gonna need a little pen. Do you have a paper? Grab one. Yeah. Songs. Okay, while we're all grabbing little papers, I am going to pull my little thingy up. So we are doing a lovely little visualization journaling moment. And I want us to all take into consideration that we are not necessarily including cancer in our conversation. What do we want our lives to look like now? We know that cancer is a part of it. We can't control that, but we have the opportunity to be intentional about what we are choosing to keep, what we're letting go of, and how we are like essentially moving through life. And I will be like active in this little chitty chat. If you want to share at any point, please raise your little hand. I think that it like raises for you. And then if you want to throw any things in the chat, I'll try to keep my eye on it as well. So we're going to start with a little values brainstorm. I'm going to put on a timer, and for 90 seconds, we are going to write down everything that is a core value. It can be things like family, it could be community, it could be health, it could be your dog. Literally anything and everything that comes to mind, write it down. Word vomit. I'm going to start a timer and go. 90 seconds on the clock. And as you're writing some of those, if you feel like you got a nice little list going and you want to start sharing anything that you've written down in the chat, feel free. You're about 40 seconds in. And 90 seconds feels like a long time when it's quiet, but it's nice. About 20 more seconds. Is there anyone who feels like they would like to share? And if not, you can just drop some of your things in the chat. So we have church family, community, sorority sisters. Yes, healing, less suffering, Time is a construct. Absolutely. Yes. Pets, job, happiness. Yes, as specific as you can get. So we're going to take these into consideration. Ooh, people just sent more. I love that. I want to read them. Yes, hair, actually, for real. Hair, volunteering, music, kindness, honesty, peace, nature. Amazing. I love. So we're going to take all of these things into consideration as we go through this little visualization. I want everyone to take a second, put your pen and paper down, and we're going to sit with both feet flat on the ground. And we're going to take a little walk through our regular day. You can join me by closing your eyes, and we're going to take 2 deep breaths. In for 4, 3, 2, 1, and out for 4, 3, 2, 1. One more. In for 4, 3, 2, 1. Out for 4, 3, 2, 1. And now in your mind's eye, you're waking up. It's a Tuesday. Notice how your body feels. Take a look around. What's the first thing that you notice? Pay attention to your senses. Are you alone? Are you with a partner? What do you hear? Take a moment and sit in this ideal morning. And take a nice deep breath as we move into our day. You are doing the thing that takes up most of your time. What is that? Where are you? Notice your surroundings. How do your surroundings make you feel? Take a moment and soak in that environment. The day is winding down. Notice the small rituals in your evening. You've completed everything that's required of you. Take note of what those things are. What are you returning home to? How are you taking care of yourself? Take a scan of your body. How is it feeling? Take note of anything else that might be important. Before you open your eyes, get your one final snapshot. A couple of those moments throughout your day that felt really good. And now open your eyes. Hello, we're back. Okay. Anyone have anything that they feel is worth sharing about what they experienced? And if you don't, that's fine. I'll give it a second. Okay. So now, oh yes, the simplicity. Yeah, actually. So now with all of those things that we've taken into consideration, I want you to take a look at your list. Which of those values showed up in your visualization? Was it a relationship in particular? Was it simplicity? Was it having a slow morning or doing like a face mask before you went to bed? Take some inventory. And if you're noticing that you're not seeing your core values showing up in your visualization, that's a really good thing to notice. Because that means you have things to let go and things to focus on. You have direction. That's great. So, with all of these things in mind, I want you to look at your list and work your way through circling your top 5. What are your top 5 core values? Think about the things that can be encompassed in something else as well. Like if you said, my mom, maybe that's family, or maybe it's just connection. Wanting a swimming pool is absolutely, maybe that's just leisure. Those things all get bundled up. Think about the things that are core values for you. Circle your top 5. And this is where I will ask, once you have your top 5, as long as you're comfortable doing so, put them in the chat. As you're looking through your list, notice which values you let go of and why. Are they that important? Is it wrapped up in something else? Does it ladder up to something bigger? There's sometimes that I feel like we get really specific on something that we want. Like, let's take the swimming pool example. And I've noticed this in survivorship specifically. Like, I'm like, I want a swimming pool. But that really ladders up for me to, I want the time to relax in the pool. I want leisure. And what are these bigger concepts that we can take and implement into our day-to-day lives to get even just a touch closer to the version of ourselves that we want to be? I'm going to read some of these. Peace, happiness, family, presence, and health. That's lovely. Presence, healing, art, nature, love, respect, adventure, laughter, care, connection, joy, peace, creativity. We have more peace, more connection, presence, gratitude. All of these things are really high arching our umbrella core values. There are so many ways to express these things. Think about which ways that you could express it that might be like in your blind spot right now. There's plenty of ways for us to express something like community. If we're sitting here today, we are in community in this room, in this virtual room. Maybe it's not the game night that you had in your front room at your house, but we are in community nonetheless. This is a different expression of the same value. Oh, connection. Yeah. More connection. So, with that in mind, I would like to journal. I love journaling. So I'm really big on what are we keeping and what are we releasing. In life before cancer, I know that I held on to a lot of things that didn't serve me, a lot of expectations of myself and of others that didn't serve me, that didn't make me happier, that didn't make me a better person, expectations of jobs. How many of these things were like put on us by society versus how many are actually in our little spirits? And the answer is surprising. A lot of them are societal. And after facing something like this, where it's like you might not get to enjoy society in the same way ever again, F all that. Like super for real. I want all of us, just like I want for myself, to be expressing the deepest core version of ourselves, ooey gooey, gushy mushy, life-loving versions. And I think that with some intention, we can all get there. We can all get a little bit closer to it. So, there's two questions with this journaling. The first one is, what do you want to keep? What is something that brings your real life closer to your visualization? The second thing, and I can repeat these again, is what do you want to release? What is taking up space in your real life that shows up nowhere in your ideal day? I'm going to read them again. What are we keeping? What is something that would bring your real life closer to your visualization? What are you releasing? What is taking up space in your real life that was nowhere in your visualization? Oh, yes. Thank you for putting that in the chat. Yeah. I'm also open to hearing what anyone has to say if they want to put it in the chat or if they want to say it out loud. I can say for myself something that I've been keeping a little too much lately and I want to release is the expectations of my body for how it looks after cancer and after reconstruction, for how it like moves, for its capabilities, and comparing it to an old version of myself. That's not doing me any good. I want to be out here in the streets with a tank top on, a little crop top with my belly out, and not a care in the world, and feeling the sun on my skin because I get to do that now. It could be something as simple as that, which is not super simple, but it. So with all of that, oh yes, releasing self-doubt. Super big. Just know that you don't have to release any of this stuff today. That's also a thing. Like we're not going to write it down and then be like, oh, it's gone. And then just dilly-dally on about our lives. That's just not how it works. But there's known knowns and there's known unknowns. And then there's unknown unknowns. The goal is to start bringing more known unknowns into the forefront and more unknown unknowns into the forefront. So you actually see what you have to work with, and you can slowly start working through what is going to work for you in this next phase and what is not. Yes, control. Control is huge. Self-doubt. We're releasing that. We're releasing all of it. Anger and sadness. Yes. For the people who have left and let me down, and for the things that I've lost along the way. Yeah. Yeah. Releasing the need to be perfect. Releasing the expectation for enough time for a long life. Thank you all for sharing in this chat. I'm going to read this one too. Release being stuck in the past or the anxiety of the future. Yes. With all of these things in mind that we're pondering, because I know like this is not a very dense like time where I'm going to talk and give you all this information. I really want to give everyone the time to reflect because everyone's journey in this is different. But I do want everyone to write down one intention, knowing that you do not have to release actively everything. It's not going to like effectively all be released, but what is your intention? What is something that you can take into next week? Maybe even tomorrow? Is it better sleep hygiene? I will go to sleep at 10 p.m. and I will spend 30 minutes before doing a red light mask because I want to take care of myself. What is one intention that you have for yourself? Anyone else that would like to share their intention in the chat, I will be happy to read it. I actually just shared my actual intention with you. I've had really bad sleep hygiene lately. And I feel good when I am like cocoa buttered up and a red light mask on my face. That is superb. Yes, being strong for your quarterly treatment. You already are. You don't, that's not even something that you have to question. Letting go of the need to control. Life is not a checklist. Staying hopeful. Leaning into moments of joy. Yay, 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 so many things. Taking care of your body. Accepting now and not comparing to a past version. Noticing nature. Yes. Breathing exercises, laughing more. These are all really good things. And that is really all I want everyone to take with them is the one thing that they said that they can commit to. This is an intention and a commitment. Can we all commit to doing our one intention within the next week? If that's a yes, then we're on the right track. I will take a maybe. I will take a strong maybe. And with that, we're going to take a little, close our eyes. We can take one final little deep breath. We're going to take a deep breath in for 4 and out for 4. One more. We're taking a deep breath in for 4, 3, 2, 1. and out for 4. 3, 2, 1. And that's really it. I just wanted to take y'all on a little adventure. And for those of you joining in September at the Wellness Summit, I will see you there. That is
Hey, that's what I was going to say.
all. Gotcha.
You did. You did. You took the words right out of my mouth. Thank you so much, Matea, for guiding us through such a thoughtful and grounding journaling experience. It was a beautiful reminder of the power of slowing down, reflecting, and giving ourselves space to process wherever we are in. If
Absolutely.
you enjoyed today's session, as Matea already mentioned, I have some exciting news. You'll have some opportunities to see her live and in person at the YSC Wellness Summit this September in Seattle, where she'll be leading some more inspiring sessions. And we would absolutely love to see you all there. Remember, it is sold out, so hopefully you have all registered. And if not, then there's always Summit March 27. And next, we're going to transition into our final part for the evening. Thank you so much for sticking with us. If you need to take a quick bio break, grab some water, some not water. We listen and we do not judge here. All for that. It looks like Kendall is going ahead and popping in that part 1 survey. If you'll take a few moments to go ahead and answer some of those questions for us while I introduce you to our final speaker of the evening. We are going to say the quiet parts out loud. From body changes to desire, communication, and pleasure, this candid session creates space for the conversations many of us are craving, but we don't always have. Guided by intimacy doula Tasha. I don't want to butcher her last name, but I know her first name is Tasha. You'll leave Dejay. There you go. I should know this. You'll leave with a fresh perspective, practical takeaways, and the reminder that your experience is valid exactly where it is. Tasha is a Bronx bred and based Haitian infused conceptual, visual, and performance artist, activist, and cultural vigilante whose work lives at the intersection of art, intention, and community care. Her multidisciplinary practice challenges ideas of identity, history, and iconography. And she explores memory, time, and nature through the lens of Black womanhood. She uses her art as a tool for reflection, connection, transformation, and collective imagining. As an intimacy doula, Tasha helps people re engage with all facets of intimacy. She advocates for deeper understanding of the word by exploring when, where, how, and with whom it shows up. She offers guidance as people navigate their relationships to intimacy through prompts and different exercises. Her work aims for people to find their way back to intimacy in the most memorable and empowering experience. Welcome, Tasha.
Hi, everybody. Good evening. I'm coming to y'all by way of the South Bronx. I am, for anyone with low vision, I'm a brown-skinned girl. I could work on my tan. She don't work on that, y'all. Need more sun time, more beach time. I am blonde. I'm sitting in my office, and I have one of my photographs in the background. So, yeah, we are here to be unmuted and have a candid conversation around intimacy. Before we start, Andrea, can you just let me know how much time I have? I just want to make sure that
We have you 25 minutes.
25 minutes. Okay. So, welcome. First of all, I just want to say Allegra and Joe, so beautiful to have y'all in this space because it's one thing to talk about intimacy, it's another thing to witness intimacy, right? And so when we talk about things, I mean, y'all just gonna lay it on thick. Look at that, look at that, look at that. And so I want to be able to, I am a type of facilitator, like I prepare and then I also am present. And I believe presence is something that came up a couple of times in conversation for also Matea's work as well. And so with that, I'm going to integrate some of the things that I've heard while I was in the room, right? And so in talking about intimacy, I also am big on witnessing. So I would love for us to start that. What are some ways in which you witness intimacy between Allegra and Joe, and also with Mateo? And we could put that in the chat. I will also want to uplift some voices. So, what did people see when they witnessed Allegra and Joe's speaking to their story, speaking to their narrative, and even Matea as there was an ushering of this activity around our own visualizations? I can jump right on in if anyone feels compelled. Oh, Vanessa said the way they look at each other. I mean, there were times it felt like choreography, right? Genuine choreography, where the timing was absolutely like, and listen, and you, right? And it was just, you can tell it was not rehearsed. 'Cause I don't know if y'all know when y'all see some people who dance, you can hear them counting in their head, and a one and a two and a three. And then there's other people that just move with the flow, and the rhythm is in them. Like the rhythm of your intimacy was very present in these confined boxes. So that was great. The emphasis on words, laughter, teasing, eye contact, touch, smile. Even as Mateo was talking, passion is something that's important when we're talking about intimacy. And so there was sometimes I would witness Mateo leaning in as offering direction and guiding us through these visualizations. And so when we talk about intimacy and unmuting, I just wanted to first uplift how, yes, they all feel genuine. Our communication, a lot of the times, well, most communication is nonverbal, right? And so while we might hear the word mute, right? We might be thinking of one's voice, but I really want to think about communication from a embodied experience, right? What are the ways in which we can unmute the ways in which we relate to each other, right? So, and I love that authenticity is coming in, calming presence. And even when, Joe, when you cursed, right? That was intimate because you were talking about a part of this experience. And sometimes it might need a little bit more color. It might need a little bit more sazon, a little bit more seasoning, right? But that passion, the way in which that inflection, that really adds to the way intimacy, and even sometimes the word intimacy can sound soft, but doesn't mean that it's not strong and it's not powerful. And so I want to uplift that as we are having these considerations on what it means to be unmuted. So I want to ask folks, I'm going to hit you up with some questions. How and who muted you? How did you find yourself muted? And was it a person, thing, experience that meant, obviously we're talking about cancer here. But did your experience of being muted happen prior to your diagnosis? Right? Because some of the ways in which we exist prior to life changes and including diagnoses can trickle into this new experience. And so what are the things that we're bringing in? Like, how did you find yourself muted? Who muted you? Were you muted before your diagnosis? Okay. Marissa said, not being heard when I asked for help. Do you care to offer your voice to clarify and give more context?
Sure. I was having panic attacks,
Mm-hmm.
and I was working with the psychiatrist at my cancer center, and the medication he put me on was making them worse.
Mm.
One of the lab techs identified something that worked really well at stopping them before they happened. And then she went on vacation, and she really saw me. She's the one person there. I'm no longer with that cancer center. She's the one person there that really saw me. But she arranged for another lab tech to make the same accommodation. And then that woman did not. And the social worker, the cancer center director, my oncologist, they all just ignored me. The psychiatrist, he didn't listen when I said that the medication was making things worse. My anxiety was just like going through the roof.
Mm.
And it resulted in things being really challenging for me during chemo. It resulted in me needing to find other care. It made it difficult to find other care. And it really affected my relationship with my family
Mm.
in really big ways.
Thank you for sharing that, Marissa. I believe,
Thank you for hearing me, Tasha.
of course, what you have brought up is a lot of things. I do have another question for you really quickly before I follow up. After the lab tech reached out and sourced another lab tech to ensure that you still had these accommodations met, what was the deciding factor for you to leave that cancer center?
While I was having a panic attack, my mom asked the cancer center director to move out of my line of vision because we had had a meeting with him where he basically just he wasn't. I mean, the lab tech was literally just bringing me into a different room, away from other people, so they didn't have to witness other people having blood drawn, like throughout my own anxiety. Not anything that takes a lot of time to just move me to a different space. And he basically was like, "Well, we can't always do that for you." Um, and then so basically, what was happening when I was in the lab was I was having these massive panic attacks. So I had a panic attack one day, and my mom knew that I didn't have wonderful feelings about him, and she was concerned that me being able to see him was going to exacerbate it. And I found out afterwards that she'd stepped into the hallway and asked, this is wild to say this out loud to a group full of people like this. She asked him to step out of my line of vision and then came back into the room, and he didn't. So she closed the door. So he called the cops. And yeah, so when she went into the hallway, the cops basically put her in cuffs, and I heard her screaming that they were hurting her and she couldn't breathe, and I didn't know what was going on, and I ran into the hallway. And then, of course, I reacted because I had already been having a panic attack, and now my 5 foot tall mother is on the linoleum floor in the hospital hallway in cuffs, and they called it in incorrectly. They called it in as a male who was barricading himself in a room, threatening to stab a staff member. And the police report states that dispatch misunderstood. And they didn't say the word stab, but the result of that was it was called in as a code 3. So there were like 5 or 6 officers. 2 of them had weapons strapped to the front of their bodies. I'm a children's yoga teacher. And before I taught children's yoga, I was a special education teacher. Like, I don't, I'm not a violent person. I'm not an aggressive person, but I reacted. And so the response of the police was to arrest me. And the cancer center director stood there and watched it all happen. So that is why I'm no longer hospital. I don't, and when I'm done with my treatment, I'm, yeah, someone in the chat just wrote lawsuit. When I'm done with my treatment, I'm going to see if I can find an attorney, but I need to finish treatment first. That's my top priority right now. But yeah, it never in a million years could I have expected or anticipated that. And I still often I can't wrap my head around like the fact that that really was what happened.
So I have a lot of words going through my mind. I have a lot of things in my body, and I don't want to mispronounce it. Tell me if I'm saying right. Anjuli? Anjuli, did I say it correctly?
Yeah, it's Angeli, like Angelina without the
Anjali.
na. Yeah.
Okay. Anjali, I was with you with all of the emotions. Joe and Allegra was coming in, but I know that within these boxes, we were having a lot of response to what you offered, Marissa. And so, like, for those who engage with me at the summit in New Orleans, one of the things that I emphasize is that intimacy, one core, important, vital part of intimacy is breath. And what you just shared requires us to have a collective breath.
Yeah.
Because deplorable, horrendous, horrific. There are a litany of words that don't even come close. It's actually what you describe feels like a domestic terrorist attack. And in the midst of what you're enduring, for that to be compounded on that, when the folks that you mentioned, familiar and familial, right? And then a part of a care team showed you intimacy by listening to you and hearing you and centering you, the response blows mine. So if we could just take a moment to just on our own pace, really feel what Marissa has offered for us as a lived experience. And also hear how, one, a lot of medical spaces mute us, right? Don't hear us. And when those who choose to unmute that practice, what happens to them as a result of that, and really sit with that, process that, allow that to move through our bodies. And then we'll come back in like 2 seconds. So a couple of seconds. So let's just take a moment to breathe deeply and be in gratitude for everyone's presence here. Because also what you said, Marissa, was very intimate. So our time together is short. And as you can see in the chat, Marissa, and through the reactions, many we're with you. In conversations around intimacy, a lot of times folks will anticipate that I'm talking about partner intimacy, right? But intimacy is expansive, right? It's our friendships, it's our family, it is our care teams, it is all of those things. And the ways in which we engage with that are imperative for not only our survival, but for us thriving. And so again, being present to what was offered today, I really want to lean into what Allegra and Joe offered. Allegra, you mentioned these manifestos, right? These manifestos that arose in your fear and all of those things. But what does an intimacy manifesto look like? Right? What are the ways in which we conjure up and intentionally a proclamation for the ways in which we want to be centered and heard and seen? And so I want to offer this definition of manifesto, which is a public declaration of beliefs, motives, and future intentions of an individual or a group, usually associated with politics, art, and social movements. It outlines a specific plan for change and is designed to inspire followers and outline a new vision. And I feel that that's very poignant to what we're talking about here. We're talking about intimacy, and we want intimacy to be generative, especially in the midst of a diagnosis, irrespective to where you are on that journey. How are the ways in which you want intimacy to exist within your life? Right? And the ways in which we talk about what are the things that that we like. And also like not that it will be perfect, but that it will set a framework. Right? It will allow for people to know how to enter, right? What these agreements are in that way. And then just thinking about, again, the practice that Matea offered us and like, what are the visualizations, right? When we want to have hard conversations, do we cultivate a space for that to become a proactive practice? Right? There was I was listening to some podcast, some video or whatever, and Jadena, who is a singer, Nigerian singer, and he talked about with his partner, one of the ways in which they almost equalized the playing fields when they had their conversations that they scheduled to meet with each other once a week. And in meeting with each other once a week, they had to be, they both chose to be fully naked. And the person that was talking to them was like, why the hell are you gonna be naked? And they chose to be naked because it was harder for them to run away. Right? When you got your clothes on, you're like, you know, my whole nerves, just, I'm out of here. Right? But the vulnerability of even being naked outside of a sexual context invited them to be present in a particular type of way. Right? Intimacy is an invitation to be imaginative. Right? Intimacy is not specific, one way, the only way, that's it. Right? It is a way in which you feel alive. Right? And as someone was talking about grief, intimacy and pleasure can help if they're not opposing each other, but they can actually help you move through the thing. Right? So another thing that I was thinking about when we're talking about being unmuted, what areas particularly for intimacy do you want to be unmuted? Because, right, we're offering a wide umbrella, but is there a particular area where you're like, I notice that I silence myself in this particular area? I can be very vocal in this area, and I'm like, what's this, man? Just literally just evading my mind. Ugh. But yeah, some things might be easier for others. And then sometimes it's not. And like, while I am here with y'all in the space as an intimacy doula, that does not mean that I'm also not practicing and learning at the same time, right? I had a partner who had severe triggers, and sometimes even like a tap like that would render a paralysis in their body. And it impacted our intimacy. And I didn't unearth and unpack the depth of that until after we were unpartnered, still friends. We were dating. And I realized I made them too fragile. I no longer presented the curiosity in which I normally show up, right? In a way that, okay, let's learn each other, let's discover each other, let's do these things. I rendered them so fragile, unbeknownst to myself, that as you were saying, Joe and Allegra, we're on the same journey, wanting the same things, but my silence and my ended up distancing me, further impacting our intimacy. And in other areas, we're fine. Can talk about anything, can do all the things. And so the way in which the muted experience shows up sometimes is not as obvious as we think. So I would love for people to share in the spectrum of intimacy, what areas are you recognizing? And that can be some of the life work, right? When you think about intimate, right? How are you intimate with your friends? How are you intimate with your family? How are you intimate with your partners? How do you articulate verbally and non-verbally your desires when they are present and also when they're absent? Hold on. I'm getting some stuff in the chat. Hold on. I'm gonna bring these up. Let's see. Thank you all so Marissa said, thank you all for hearing me and thank you for your support. I've never expected to say that out loud to a group like that, but I think being seen by so many of you is healing. Thank you so much. As I shared, these are intimate moments. Let any shame be magically dispelled because shame is blame turned inward. Ooh, really? Yes. Yes. I love that. I love that. Thank you. Yes. Um, Going back to menopause talk, having an evolving treatment manifesto for doctors about what matters to my life and my health. Yes. Kathy offered, my ex-husband, I was never listened to. I had to do most things on my own. I brought that into my diagnosis by not asking for help and presenting as strong most of the time. Oof, oof, oof. The offering after that is like, I hope that your divorce has helped you find your voice again. Let's just talk about strong. Strong. Strong has almost become a curse word, right? In strong, forcing you to perform, right? I'll speak from the I in order to remain intimate for myself. And that's another thing I want us to consider as we're moving through these questions. How are you intimate with yourself first and foremost? First and foremost, we have to cultivate a praxis of intimacy with oneself. And that can be the visualization practices, that can be the meditation, that can be how do we set the ambiance in our spaces, right? The way in which that happens. But that thing about being strong and performing does not allow you to be intimate. It's a mask. It is a mask that someone sometimes ends up like a fortress, making it harder for one to permeate that, right? I'll tell y'all right now, when I go to the doctor's office, I do not tell them that I have a high threshold for pain. I want you to think that if you poke me, you graze me, I'm going to be screaming from the mountaintops. Like, nope, nope, I'm going to be screaming. I want you to be, because that is a form of protection for this body. A way that I can intimately care for me when I already know that there are preconceived notions around what my body can take outside of my voice. Right? So when we talk about intimacy, my experience has been people have come to me and they've asked me for guidance on how to be intimate with others, ignoring how to be intimate with themselves first. Right? Especially since you are the one that's going through this lived experience, right? And so there's a ripple effect for those who were present in when we were present in New Orleans. One of the things that we did an exercise was around transference. That's a real ripple effect. I'm scared that you scared that I'm scared that I'm gonna mess up. Ooh, coming into the house. Ooh, the walls are like, figure it out. Guys, it's not even real, right? The anxieties are impeding the presumptions, the assumptions, all of that is impeding on how one can show up. And what was beautiful is that we got to see multiple iterations. There was a husband and wife couple, they're facing each other, they're holding each other's hands. And the wife was like, my husband really showed up for me. And it was just amazing because we were doing breathing exercises. And she's like, I feel so comfortable. And the husband was like, I am stressed. I'm stressed. Now, while they are being received as an anchor, they are on shaky ground, nervous and having a trepidation around not being the perfect support. Right? Another example of this potentiality of transference of energies is that we had another couple. The woman was sitting in front, the husband was, in the back because it was a packed house. Like, this is a packed Zoom room. I love this. And then immediately it was like, oh, I feel a presence of being watched. This is their partner. And so listening to the ways in which they were describing their presence in the room really illuminated for them, while it doesn't mean that they're at odds, but it illuminated for them something that could potentially impede on maybe a conversation that would come up, on an action that's needed in that moment, right? Because there weren't ways in which they were considering potential blockages around their intimacy. And that all came from a breathing exercise, right? So how are we breathing with ourselves? Do you touch yourself when you're breathing? Do you have your hand over your heart? Are you paying attention to the ways in which, what is the touch ritual? I believe Matea was asking about rituals. How often are you touching yourself? And I'm not even talking about masturbation. I am a proponent and advocate for masturbation. And also simply caressing your scars. Re-engaging with these trauma sites, right? As Allegra offered, not letting the experience hijack the potentiality of the present and the future. And by no means am I saying that to be, oh, this is a real easy journey. No. But in the manifesto, what are the practices that you are creating for yourself to make it a praxis to return to self in an intimate way? Any thoughts and comments as I start to go through the chat? Marissa, everyone's trying to get you a lawyer. Everybody trying to get you a lawyer, okay? They want to make sure you get that check. Woo! Man. Okay, we're still talking about leavings. Well, no, just spouse wow. Do you mind? Oh, yeah, we're doing the exchange and all the things. Okay, Miranda said, I regret so badly not having a whole face when I was younger because now I'm 35, 3 years into my diagnosis with zero sex drive. It was supposed to be my prime. I feel so guilty and sad for my husband. He is so incredible, but it feels so crazy to have gone from every moment ready to go to not even thinking about sex. It feels so foreign. That's a very real scenario. And what I will offer as a consideration, Miranda, is how do you reimagine sex? How do you reimagine sex? Because there are many people in their whole phase right now having bad sex. They are hoeing it up. They are out here hoeing it up. And it's terrible. It's a monstrosity. It's like, you know what? Let me go to the convent because this is not it. They're trying to get rid of their whole card. Right? So are you asking to be a hoe or are you asking for a pleasurable experience? We got to put that into context. There are a lot of angry hoes. They are pissed. Okay. I let her enjoy cracking them. But I'm serious. I know some of these hoes. They are upset, pissed, because even as a hoe, you still want pleasure. Half the people don't know what the hell they're doing. Okay. Can't breathe right. You know, you're struggling to orgasm because you're not even breathing. You don't know if the person's having a stroke, a heart attack. Like, what are the signs? They forget to breathe. They forget to be present. So again, when you ask yourself, oh man, I wish I would have my whole phase. I feel bad for your husband, right? Intimacy is also about communicating, right? How do the two of you reimagine pleasure with and without the physicality of it? Like, what makes it different? There are some people who, have you thought about tantric sex? There are some people who are orgasming because the wind blew. Oh, what? Like, I want that. But then I don't want that because then the wind blows often and then I won't be able to function. So it's like you got to be really considerate about what you're asking for. Do you know what I mean? Like, we gotta, right? There are people that don't require touch and get pleasure, and they are fine, right? Think about it from an abundance mindset. Like, some of this sex out here is very scarcity minded. Okay, very basic. It's and it's like, oh God. No lube, and we're thinking about diagnosis. Dr. Mann was on just talking about like hormone rings. Like, there's so many other things to consider from the perspective that all of y'all are talking about, right? We don't want to go back to basic, right? How do we reimagine this in a way that takes it to another level? Like, I don't know if people still color, but the Crayola box, you have the 24, 48, 96, and then you come in there with 128 with the sharpener in the back. Like, how do we get there? And that is through imagination, right? The red is no longer red. It's crimson. It's maroon. It's, what I'm saying? It's rosacea. You know what I mean? Like, there are hues to that. Like, how do you incorporate the hues so that intimacy can come back? Because what was pre-existing was pretty damn boring. So I'll go off my soapbox on that one. I just want you to remember, some of these hoes is not that happy, okay? Some of these hoes are not that happy. Yes. Death and disease is very intimate. That's why they wreak havoc. One of my friends is a death doula, right? That is an intimate job. To be able to hold the reality that someone is going to transition and not only be in support of the person that is doing that transitioning, but the family around that. Right? And helping one to prepare and strategize around that is an intimate practice. Right? And so again, all of these facets of our life require some consideration around intimacy. All right. So Brittany said, I have no energy or sex drive to be intimate with my boyfriend. Valid. I'm going to say the same thing. What does that even look like? Are you using the same baseline of what was before, or are we being imaginative? I remember one of the folks that I was working with was just like, I have no nipples, went through double mastectomy and did not have nipple reconstruction, but then had the scar. And one of the things that we talked about was like, well, have you thought about like painting on your breasts? She's like, what? Take some non-toxic paints and you can paint the breasts. You can ask your partner to paint the breasts. And one of my workshops, we did painting while folks were blindfolded and just starting on the arm, the sensuality of the cool paint on the skin, some of it being textured, feeling how some of it like dried up, flaked off, all that. They were like, what? Your 99-cent store could be your friend, right? There are ways in which the pressure of returning to sex in the way that we have been indoctrinated to experience it is blocking the mind from thinking of something more, right? Allow yourself the gradual process. Like I believe it was Joe that you said too, this process is not a sprint. You do not get an award for returning back to where you were, because usually back to where we were was not that great in the first place. The reward is gained through risk. The reward is gained from trying something new. The reward is gained by trying and discovering. I like that. Oh, I love to see people's face when they say that. I really think I was going to like that, but that's not too bad. And it might be bad with the next person. Understand that. It's always in flow. Right? It might be good with one, it might be terrible with the other one. And this is where one's own agency and unmuting allows for them to continue to show up. All right. So Brittany said, I feel like I don't have the energy to be intimate with friends, family, and then you know what? Okay, you're exhausted. Then you know what's intimate? Rest. If you're so exhausted, rest. And make it some good rest. Put the best songs on. Let me tell you something. One of my friends made a bath bomb thing that was so immaculate. I thought I stepped into satin in my bathtub. It felt so good. I was like, I have to put on this negligee that I've had for years and never worn. That's how good it felt. I had bath bombs. I had all this, but the way that I don't know what kind of I don't know what ingredients. They're all natural, but never could have anticipated it. But by cultivating with intention something for me, man, it leveled up. I was scouring my drawers to find that. Where is it? Because I wanted that sensual feeling to continue. So for all of us that are in the room that are like perpetually exhausted, I beg of you, please start with rest. Rejuvenate yourself, pour back into yourself so that your body's not in overdrive. Right? People who have not experienced what y'all have experienced are tired. Why shouldn't you give yourself what your body is desiring after what your body has gone through? So offer it what it's begging you before it will, because you know how the body works. If you're too tired, the body will shut you down on its own. And we don't want to get to that point. Right? Okay, so Anjali said, it is exhausting when you are living in alternative realities and others don't do a lot of work to come visit your world with you, and you're always having gone to this. Oh, that ain't. Do you want to speak more about that?
Well, I was just kind of commenting on like relating to the experience of finding social engagement exhausting. I mean, I don't feel socially exhausted here. As you guys can tell, I'm chatting away. But I think it's just like the realization of how much work it is to show up for a friend. And it's like you have to pull so many things together just to kind of get there on time, make the plan. And unless they're a really good friend, they're not seeing this invisible effort, and they're not, and it's not even their fault, but it's like you're just slowly kind of like living in these different worlds. And it's rare to have a friendship that is intimate enough to be so present to the other person, to be like, wow, like what would feel good to you, as opposed to like, let's do the things we used to do so that like I can have a sign that you're doing better. Or
Mm,
when what's on your mind is death, and that's not, all of a sudden you run up on this thing that is taboo in a friendship that at the age of 35 wouldn't have fucking come up,
mm,
except for like this experience that you're having. And so, I mean, I just think that most people are not able to like jive with that and kind of evolve with that, but some are, but you only need one or two, and I don't know, like that's why socializing with friends feels exhausting to me. It's like I
mm.
don't socialize anymore. It's more like I want to be with somebody. Like, yeah, anyway. Yeah.
No, not anyway. What you offered is very valuable. And I'm going to give you my lived experience as being the friend that shows up, right? And what I find is that even though I'm the friend that shows up, there is a reluctancy for my friend to tell me what she's actually going through,
Right. Of course,
right?
because that's
Right.
part
And
of the self-muting is like, yeah,
exactly my point. So as we're talking about bringing people into our world, by no means, I'm not saying hit them up with a litany of all the things that you have,
right.
because the real conversations that I've had with my friends is like, I don't want to have to regurgitate all of the experience of
Yeah.
my illness. And I don't want to
No.
do that.
Right.
Noted. But for the times, for example, I'll just give you, I had a show opening and one of my best friends surprised me, has a autoimmune disease, right? Among some other things. And she came in, she's talking to me, and I'm seeing she's starting to like slow down. She just told me, then she tells me that she had an infusion and she's trying to work through it. Girl, bye. Go
Mhm.
home.
Right.
Go home. Right. And so
Yeah.
the work is, what can you share that's not too much, that makes the reality of your
Hmm.
world more present? Right. What I
Right.
have experienced is that a lot of times, 'cause the framework is, I don't want to be a burden,
Yeah.
right? You don't need to know all these things. I can muster through it. I
Hmm.
can show that strong word comes up, and it renders your lived experience behind the walls.
Well, and also I think that, and
Sure.
this is more like, I think sinister than the general things, but like I think that people transfer and project their anxieties like onto you, right? So
Okay.
like, um and so there's this weird taboo, and especially people who are younger, it's like I watch like older people deal with like lots of people dying, and they have developed like these ways to go to a funeral or talk about it. But like when you're at this age, we just don't have a lot of experience with that, and so people's own fears can get triggered, and
Mm-hmm.
it's not fun being a trigger for other people and their fear of death, or like their trauma around their mother that died of breast cancer, or the fact that they haven't gotten their mammogram because they have anxiety, but then they're like compulsively talking to you to kind of, so the mind games that people play just because of human, you know fear, it's just weird being a person that triggers that for other people, right? And so, yeah, that that's an
Everything you said,
experience. Yeah.
everything you said is 100% valid.
Mhm.
I'll only speak from the eye, and what I've experienced and witnessed is that there is this reality that you spoke about that many people in the group will affirm. The thing about when we, and I'll put the we in this, choose to not do differently, that remains, right? It remains. So as people are trying, because there's some genuine people that want to know how to show up and they just don't know. Like, Joe was talking about it. Like, I want to come in, I'm trying to fix it. I'm trying. I don't know, right? But the presumption goes both ways, right? Sometimes the person experiences presuming that I'm going to be triggered, and so they don't do the thing, and then I don't get to come in. And so now we're both doing the thing, and what remains is the stagnant. What remains is that we don't get to be intimate together. And intimacy doesn't mean it's always going to feel good. That's the misconception. Intimacy is like, yeah. No. Intimacy means that sometimes we might get it wrong, but we're going to be present on how we can communicate through it. That's the part of intimacy. The risk in, I'm going to try. We're going to do this dance. This dance might not feel good. Someone might get hurt. Someone is going to be stressed. But we can't learn to do differently if the field to practice doesn't exist.
Right. But I guess, like, do you see how all of a sudden you are really learning who in your world can be up for that? Not that they need to do it well, that's not even the point, but it's like, I just, in my own experience, and I don't know if it's the times we're living in or COVID, like, I don't know what it is, but the lack of time and the lack of intimacy, you start to see that that's a subset of, like, the people that you previously filled your life with. And maybe that's what happens when you grow older, and it's just, like, accelerated with this experience. And it's not a bad thing, but it is a challenge that's, like, unexpected, I think.
I'm going to answer this, and then because I know I probably are running out of time. What you said is very beautiful, and underneath that is a fear that has come up in conversations with my friends, some of the people that I've worked with, right? The loss of those who are already present, right? The finding out that the people that you love can't do the thing in this moment that you want them to do. And you went from like 10 people to like, damn it, 2. But the 10 people occupy space in the same way Matea was offering us, is like what needs to be released so you can have your peace. And sometimes you may have to let some folks go in that moment, and sometimes they return. Sometimes they come better so that you can figure it out, and sometimes it makes space for people who can. Right? And that allows more intimacy to come into your world. That allows for more people to be able to hold you in a way that you didn't think you couldn't, right? You'll get the untimed but timed perfectly looks with like Allegra and Joe, right? You'll get the touches, you'll get the steps that will bring you closer to your visualization. And it's hard as fuck. It hurts. As a society, we're not taught to grieve these relationships. These deaths that occur outside of the physical, right? But the relational, right? And because we are not groomed to manage that in gratitude, right? You know what? These past 22 years was good. This 21 year, not so much. I'm gonna let you go. Thank you for your time. In gratitude, because they're not meeting you where you need to be, vice versa. And it's intimate to release. It is intimate to let go with care. And so those are the things that I will ask for y'all to like just consider and think about as we're cultivating these intimacy manifestos. What are your declarations for the ways in which you want people to engage with you as milestones, as frameworks, as benchmarks for the way in which you want to engage? All right, I'm gonna go down. Yep, the strong word. Brittany was like, yep, I'm not strong. I'm not even though others might see it, I'm barely holding it together and just doing what I have to do to get through life. I will say that I've air quotes the strong friend, and I have told my friends I will throw the SOS at your head and then tell you to come save me. I don't got that kind of time. Time is too precious. Time is too intimate. Like doing it alone, it only exacerbates it. And it's intimate to let them know that you're like, oh, she doesn't feel that she's so strong that she can't reach out for help. So again, reframing that strong part. Kathy said, I went through treatment during 2020. Chemo started in January, radiation in July, plus 2 surgeries. I had to be strong or fine and do things on my own because I had to. This was all after losing my dad to his cancer battle a month after my diagnosis, and then getting a cancer diagnosis for my dog at the same time. Woo! Kathy, I want for you one intimate thing. Just find one intimate thing specifically for you. Because that's a lot. That is a lot. Yeah, lymphedema is a whole nother joint. Elizabeth says Elizabeth is having a Zoladex injection. Wish me luck. All right, everybody. Wish Elizabeth the good vibes. Okay. Sarah's sending them to you. We're sending you the good vibes, right? Community is also intimate. Vanessa says, my most intimate moment has been looking at myself in the mirror, see my no reconstruction chest and scars, and to accept, to love, and to understand that new me. And to be strong is to take the toxic positivity mask and right there recognize that it is okay to not be okay. Ashe. Touch my scars, feel the feelings, be there, naked with the new version of me. Talking about. Miranda says, so much of my pleasure came from my nipples, so I don't know. I am sad and I'm so sad. I want to affirm that that was a central point for you, Miranda. I also just want to say that, we're talking about sex ed. They gave us like 3 zones: titties, ass, genitals. That's all they really gave us. Titties, ass, genitals, right? But your skin is the largest organ. Play with all parts of your body. You might find that this might be as sensual, as pleasurable than your nipples underneath your arm. I see you, Kendall. I'm coming. Like, play around, find some other ways in which, we may have been conditioned. I'm a chesty girl, and I'm gonna tell you right now, the nipples ain't it. That's the key. That's the gotcha. My nipples ain't it. But that's my experience. But what I'm saying to you to say is that there might be a new erogenous zone waiting to be discovered by you. I don't think we have time to go through all this. Miranda says, I still want to be a hoe, but I don't even think about it anymore. I'm gonna find me one of these hoes that ain't too happy so they can tell you that there is another life outside of that. I'm gonna ask the YSC team to send me all of the additional comments so that I can answer that at another time. I really hope that this was generative and that you feel that your notion of intimacy has expanded in real time, and know that it is available to you and it's just waiting for you to say yes.
Thank you so much, Tasha. That conversation, it got really real there for a second. We really appreciate everybody sharing. Tasha, thank you so much for having a continuation of your talk from Summit New Orleans. We hope to have you join us again really soon. Kendall has already popped in the part 2 survey for you guys to go ahead and fill out. Again, I hope tonight's conversations reminded you you're not alone and that there is a community here to support you through every stage of your journey. If you enjoyed tonight's event, we'd love to see you in person at YSC's Wellness Summit this September in Seattle. Over the next few days, we'll be sending all of our attendees a follow-up email that includes the session recordings, presentation slides, speaker resources, and additional information that was shared throughout tonight's program. Thank you again for being a part of the YSC community. Until we meet again, take good care of yourselves, continue leaning on one another, and we'll see you guys next time.
Bye, everybody.
Bye.